My name is Elina Eihlere. I'm general practitioner resident from Latvia, and I'll be presenting a clinical case, C-ANCA associated vasculitis and pathway to diagnosis. So, sorry. C-ANCA associated vasculitis is a rare autoimmune disease affecting the respiratory and renal systems. It often presents with non-specific symptoms, complicated early diagnosis, and this case highlights the importance of timely detection and treatment in young patients to prevent severe organ damage. About the particular case, so it's about a 21 years old female that had a history of right femoral artery embolism in 2015. So she was 15 years old at that time. But now uh, it happened in 17th January 2022. She presented with weakness, runny nose, headache, mild cough, and fever. And on the next day, she consulted her general practitioner who initiated a symptomatic therapy. And we all should remember that January 2022, all considered to be COVID, any mild symptoms considered to be COVID. So she took a COVID test like every other day, which was negative through all the illness. Next, the symptomatic therapy was ineffective. She had her lab tests done, which showed elevated inflammatory markers. Next, her chest X-ray revealed bilateral pneumonia. On next day, she consulted a pulmonologist who started her on antibacterial therapy with clarithromycin, 500 milligrams twice a day. But her condition still worsened. She reported coughing and blood, which she hidden for like a week, and below skin lesions appeared on her lower legs, like we can see in a picture. And due to suspicion of atypical pneumonia, she was hospitalized to Liepaja Regional Hospital on 29th of January 2022. And next, she had her CT scan, chest CT scan, that revealed bilateral pneumonia and suspected intrapulmonary hemorrhage. And she had a lot of testing for possible bacteria that could have caused this pneumonia. All were negative, like Legionella, Mycobacterium tuberculosis, and other. They were all negative. Next, the pulmonologist noticed that her creatinine levels were increasing, and also there was a presence of protein in her urine. So they consulted the nephrology department that suggested ANCA screening. And on 2nd February, her C-ANCA levels were higher than 200 units per liter. Then the treatment with Solomedrol was initiated, which is methylprednisolone twice. And later, she was transferred to Paul-Stradinch Clinical University Hospital. And upon admission, she continued coughing and blood. She was hypoxic, requiring oxygen therapy. Her creatinine level was 104. Given the clinical and laboratory findings, a multidisciplinary consultation was held, leading to pathogenic therapy with Solomedrol, total of 3,000 milligrams, rituximab, which was 375 milligrams per square liter, and total dose of 700 milligrams, and 5 sessions of plasma exchange due to pulmonary hemorrhage. Also, there was a kidney biopsy that revealed presenting and necrotizing glomerulonephritis. And also during hospitalization, she had recurrent nosebleeds, and sinus CT scan revealed nasal septum mucosal ulceration, and her kidney function worsened with creatinine peaking to 251, requiring continued pathogenic therapy. Also, her inflammatory markers increased. She started on antibacterial therapy with piperazole and tazobactam for 14 days. Later on, her follow-up chest CT scan showed positive dynamics with resolution in intrapulmonary hemorrhage. Her C-ANCA levels decreased to 141. On 16th of February 2022, B lymphocyte levels were also assessed and found to be 0 in absolute counts. Therefore, there was no indication to rituximab therapy administration. Also, due to anemia, she received erythropoietin therapy and iron infusions. Later on, her oxygen support was gradually reduced and eventually discontinued, and kidney function showed improvement, and she was discharged on 24th of February 2022 with following recommendations, which included methylprednisolone 48 milligrams once daily, and as a result of kidney damage and corticosteroid use, she developed secondary hypertension, which for she needed to take antihypertensive therapy, lercanidipine, moxonidine, doxazosine, also omeprazole. Due to immunosuppression, she took Bisaptol, which is sulfamethoxazole trimethoprim, 480 milligrams once daily. RNS 40 milligrams once weekly, which was later once in 2 weeks. Also, corticosteroid use led to impaired glucose tolerance, and there was no need for pharmacological treatment, but she received lifestyle and dietary recommendations. For first 6 months per discharge, she had monthly nephrology follow-ups to assess the need of C-ANCA pathogenic therapy. Follow-ups then became less frequent, every 3 to 6 months, with gradual glucocorticoid tapering. And at present, she has no symptoms of vasculitis exacerbation, and no additional vasculitis therapy is required. And she completed induction therapy with rituximab 700 milligrams in 2 doses, separate timings, maintenance therapy of 500 milligrams in 3 doses. At the latest, her C-ANCA level is 13.2. As her maintenance therapy course is complete, there is currently no active disease. Nephrology follow-ups are like 8 till 10 months, and she receives symptomatic therapy as needed, which is antihypertensive therapy. And her main diagnosis is C-ANCA associated vasculitis with renal, pulmonary, skin, and oral organ involvement. Also, as the complications, she developed secondary arterial hypertension, secondary glucocorticoid-induced glucose tolerance disorders, and glucocorticoid-induced bilateral cataracts, which she had surgery on her left eye in 2023. And at this moment, she doesn't need a surgery on her right eye. And in conclusion, this case highlights the importance of early recognition and treatment of C-ANCA associated vasculitis in young patients with non-specific symptoms. Timely identification of elevated C-ANCA level led to diagnosis, and regular follow-ups are crucial for managing this disease. Early diagnosis and targeted therapy are vital for achieving remission and improving prognosis. And this case serves as a reminder to consider rare conditions like C-ANCA vasculitis in differential diagnosis, especially when symptoms persist despite initial treatment. Thank you for your attention.